we will come now to the Professor Ehab for his lectures, ultrasound upper airway management. And just I want to tell you his lectures are published just 8 days back in the Physiology News. So it is very fresh, and I am sure you will enjoy his lecture. Welcome, Professor Ehab.
Good afternoon, everyone, and thank you very much for this wonderful opportunity to present at the Abu Dhabi Anesthesia Conference and Anesthesia Club. And I'm looking forward to also come to Abu Dhabi next month to present at the conference. And thank you very much, Yasser, for your wonderful introduction and for your generosity for inviting me. And I'm really grateful to the Abu Dhabi health system. So now we are talking about the use of ultrasound for upper airway management. So the management, the upper airway is a crucial skill for the for upper airway is a crucial skill for the anesthesiologist and other medical specialties. Also, inadequate airway management remains a major contributor to the patient morbidity and mortality, and recently ultrasound has gained the importance as an effective bedside tool for upper airway, for airway management. So in order to think about using the ultrasound for upper airway, you have to look at the anatomy. We can start first of all of the mouth and the tongue. So we use the curved probe is placed in the coronal plane just posterior to the mentum and move posterior until the hyoid bone is reached. This view will visualize the floor of the mouth, muscles of the tongue, and any pathological conditions you would like to say. Width of the tongue can be measured also using the Doppler to localize the two lingual arteries at the enter the tongue at its lateral border. And this is here you can see that how we can use the curved probe and put it in the floor of the mouth and the below and the beneath the mentum, and they can move a little bit posterior to visualize the mentum and the floor and the tongue. And you see here, this is the tongue and the width of the tongue, and we have here the mandible in the green and the tongue in the red, and the dorsal surface of the tongue as you see in red. This is also when you are doing that, you can visualize the muscles of the tongue. You have the myelohyoid muscle, you have here the genohyoid muscle, and here you have the genoglossus muscle, and also you can see the submandibular gland, and also this is the hard palate. The floor of the mouth, when you are going to the sagittal plane, you can see also the myelohyoid and genohyoid muscles are visible as the linear hypoechoic bands extending between the mandible and the hyoid bone. A genoglossus and hypoglossus muscle lie deep to genohyoid muscle and can be seen running in a fan-like fashion toward the dorsal surface of the tongue. Hard palate appears as a curvy line, hyperechoic line. And here we go. Sagittal plane, also we use a curved probe because we need a deeper penetration. And we have here the mandible here, and here have the hyoid bone here, or the mentum here of the mandible, of course, and the hyoid bone here, myelohyoid muscle, the genohyoid muscle, genoglossus muscle, hypoglossus muscle, soft palate, and hard palate. In order to increase the visualization, you can ask the patient to swallow a little bit of water, and this can have a more contrast, and this can also make more visualization. So for the most important structure in the upper airway is the hyoid bone. And we can have the hyoid bone can be visualized using the transverse view using the linear probe and the superficial hyperechoic and inverted U-shaped linear structure with posterior acoustic shadowing. This is the hyoid bone. In the sagittal plane or sagittal view, using a curved probe, we can see the narrow hyperechoic curved structure that casts an acoustic shadow. How we can visualize that? We can here, as I said, let the patient to swallow a little bit of water to increase the contrast, and we can see the hyoid bone here, and we say the mandible, and this is the water, and this is the tongue. And of course, this is the hard palate. And of course, that is the mandible is green, and this is in yellow or orange is the hyoid bone. And it is like inverted U-shaped structure. The second most important structure we have to speak about, the larynx. Thyroid and the cricoid cartilage show variable but progressive calcification with age. However, the most important to understand that the epiglottis stays non-calcified. That means hyperechoic, and that is helping to keep the flexibility and mobility of the epiglottis intact. And this functions to protect the upper airway against aspiration and choking all over your, extending the span of your age. Even 90, 100% or 100-year-old, the epiglottis is still non-calcified. And this is very important to how God is so wonderful in his creation. Also, the second most important structure, the thyroid-hyoid thyrohyoid membrane, which is provide a sonographic window through which the epiglottis can be visualized with the linear transducer in the transverse view or the short X, of course, or view of the epiglottis. We can see that. Here we go. You put the linear probe in the transverse view between the thyroid cartilage and the hyoid bone, and they have here the epiglottis, and this is the thyrohyoid membrane, and this is the sternohyoid muscle, and this is the epiglottis. Epiglottis is a hypoechoic structure, and in front of it, the pre-epiglottic space with fat, and it is hyperechoic. And this line beneath the epiglottis, it is the air mucosa interface, and it is an hyperechoic. And it is very important, and we're going to go to understand, to measure the distance from the skin to the epiglottis, and we are going to say that how that important later in the presentation. If you go to the sagittal plane or the long view of the epiglottis, you are going also have the thyroid cartilage, you have the hyoid bone, you have the thyrohyoid membrane, which is usually hypoechoic, and beneath it, sometimes we can see the hyperechoic, the air and the air mucosa interface, the epiglottic space filled with fat, and it is hyperechoic. And this is the epiglottis, which is hypoechoic because it is no calcification of the epiglottis. And then beneath it, the hyperechoic, the air intermuscular interface. So the thyrohyoid membrane, as we say, appears as a hypoechoic structure. Deep to it is the hyperechoic pre-epiglottic space containing hyperechoic fat. The epiglottis appear as a hypoechoic structure. Deep to it, it is hyperechoic white line, which is, as we say, the air intermucosal interface. And in the long eggs, the thyrohyoid membrane can be visualized as a hypoechoic line between the hyoid and the thyroid cartilage. And posterior, this is repetition what I said. Posterior to it also, it is the hyperechoic pre-epiglottic space, which is filled with fat, and it is hyperechoic. And it is another image and another view, and we see they here in the sagittal plane as well. And this can show you between the thyroid and the hyoid, and this is the hypo, and this is the thyrohyoid membrane, epiglottic phase, and this is the epiglottis. The second most important structure in the upper airway, thyroid cartilage. Thyroid cartilage is best viewed in the short X of the transverse view of the upper neck, while the neck is slightly extended. Thyroid cartilage appears in an inverted V-shaped structure when the thyroid cartilage is hypoechoic in the short X view, we can visualize through the thyroid cartilage the whole structures of the larynx. However, if it is calcified thyroid cartilage as advanced age, the vocal cords could still be seen by scanning cranially to the thyroid notch and angled caudally. The arytenoid cartilage could be seen to each side of the midline of the cricothyroid membrane with 30 degrees angulation. Here we go through the thyroid cartilage, and this is a transverse view through the thyroid cartilage. We can see the arytenoid cartilage. We can see the vocal ligament. Vocal ligaments usually are hyperechoic, and we can see here the vocal cords, and we have here the thyroid cartilage, and this is the sternocleidomastoid muscle. This is another transverse view of the thyroid cartilage and vocal cords with high frequency transducers, arytenoid, and we have the thyroid cartilage, and this is the thyrohyoid muscle and sternohyoid muscle, and this is the thyroid cartilage. So the other most important is the cricoid and the cricothyroid membrane, cricoid cartilage and cricothyroid membrane. Short X view, where the linear transducer is placed initially at the level of thyroid cartilage and slid inferiorly, the CTM or cricothyroid membrane appears as an echogenic linear structure demarcating the AM interface of the trachea. Long X view, where the probe is placed at the level of the thyroid and the cricoid cartilage, can be as the CTM can appear as a hypoechoic structure appear to the hyperechoic AM interface. So the hyperechoic interface can give you an idea where is the CTM, because it is hypoechoic, sometimes can be very difficult to be visualized. The cricoid cartilage appears as an hypoechoic appearance in the long X view as an arch-like structure in the short X. We can see that here. We see here in the long X or the sagittal view or by the linear probe, we can see the thyroid cartilage, cricoid cartilage as the hypoechoic, and here the hypoechoic cricothyroid membrane. If you couldn't identify it, just look for the air tissue interface hyperechoic line. And this is for the short X, as you see, the cricothyroid membrane, and here the air tissue interface, and this is sternocleidomastoid, and this is SM, sternocleidomastoid muscle, or sternohyoid muscle. This is another long X. You can see the thyroid cartilage, cricoid cartilage, cricothyroid membrane. It is hypoechoic, and the hyperechoic AM interface. So the cricoid cartilage appear as a hypoechoic, rounded, that serve as a reference point in the long X view. Tracheal rings, and this is very important part of the upper airway, are hypoechoic, and they resemble a string of beads in the long X or a string of pearls. In the long X, short X view, they resemble an inverted U-shaped, highlighted by hyperechoic AM interface and reverberation artifact posteriorly. And we are going to see that. This is in the long X. We have the cricoid cartilage. We have the cricoid cartilage here. The C is the cricothyroid membrane. They are the tracheal rings, and they can be seen as the pearl of strings or the strings of beads. And remember, in the long X, there are hyperechoic, and beneath them, the hyperechoic AM interface. And this is the cuboid shape cricoid cartilage, and this the cricoid cartilage cuboid shape. And here, the C here is the cricothyroid membrane. And it is, as you see, hypoechoic, and beneath it, the hyperechoic AM interface. This is another view. We have here the cricoid cartilage, and we have here the tracheal rings, as well as a pair of strings of beads or strings of pearls, and the AM interface. This is in the short X, and you see that the become here the hyperechoic and inverted U-shaped because the AM interface and the reverberation of the acoustic shadowing. How about the clinical applications? We examine now the upper airway, so how the clinical application of the focused upper airway ultrasound. Number one, the most important, difficult airway. Upper airway management carries a risk of complications. Emergent airway in the emergency department has 12% incidence of complications, such as esophageal intubation, mainstream intubation, hypotension, cardiac arrest. Mallampati score is only 51 to 53 sensitive for predicting difficult laryngoscopy, and 17% sensitive for predicting difficult bag valve mask ventilation. The POCUS is a good non-invasive imaging tool for airway assessment in both anesthesia and emergency medicine setting. If you remember the first slide, I say to you how you can predict the upper airway or the difficult intubation. You can measure from the skin to the epiglottis in the transverse view and between the hyoid and the thyroid cartilage, and you can see the distance here is 0.89 centimeter from the skin to epiglottis. This is an easy intubation. However, here when increase the distance to 2.7 centimeter, this can expect for you that this patient will be the risk for difficult intubation. This is another image. This patient 1.69 and this patient 3 centimeter, and it is highlighted here, the epiglottis. This also can predict, and this is in the patient in B and C on the same patient, of course, but the predicting difficult intubation. How about the hypomental distance? That is the distance measured between the hyoid bone and the mental. And hypomental distance ratio, and is defined as the ratio of hypomental distance, the hyperextended neck position to the hypomental distance in the neutral position. The HMDR reflects the occipito-atlantoaxial complex extension capacity. And so the HMDR is a predictive of difficult laryngoscopy. They found that the HMDR cutoff value of 1.2 discriminates between the patient with easy versus difficult, because, and this is very intuitive, if you have the hypomental distance and the hyperextension is higher or bigger or greater than the hypomental distance in the neutral position, this means that you can extend the neck properly. If it is low, this means that you cannot extend. This means can predicting difficult intubation. In morbidly obese, they found that the ratio between 1 to 1.5 in morbidly obese patients was found to have high sensitivity for difficult intubation. Tongue thickness of more than 6.1 centimeter measured using submental approach, that what we see in the first couple of slides, that when we see the floor of the mouth, we can measure the thickness of the tongue. We found that large tongue thickness to the cyromental distance ratio of greater than 0.87 can predict difficult intubation. Also, however, recent meta-analysis, and this is just published in Anesthesia and Analgesia this year, a couple of months ago, found that the heterogeneity in the performing ultrasound and the limited number of studies does not allow a definitive conclusion. Thus, the routine use of the ultra to predict difficult laryngoscopy still cannot be recommended. However, my understanding and my recommendation, if you have the ultrasound and you have a patient, you can predict or can have assumption in your mind when you are doing this measure that this patient might be a difficult intubation, and prepare for yourself. All of us have the ultrasound, and you can use it as a tool for in the OR or ICU setting. So use it, and it might be helpful for you to have the suspicious for this difficult intubation. If it's not difficult intubation, well and good. But if it's difficult intubation, you already have all the equipment available and can predict the difficult intubation, and you will be well prepared. So that is very interesting about using ultrasound for confirmation of the endotracheal tube. Capnography less reliable in patients following bag valve mask use or recent ingestion of carbonated beverage due to increased carbon dioxide in the stomach and esophagus. In the same time, less carbon dioxide produced in patients suffering from pulmonary embolism, cardiac arrest, significant pulmonary edema, or severe bronchospasm, you cannot find capnography. The quantitative waveform capnography is only 60% to 68% sensitive for endotracheal intubation during cardiac arrest. Transtracheal ultrasound is 98.7% sensitive and 97.1% specific in adults for endotracheal confirmation. Linear transducer is placed transversely across the suprasternal notch to reveal air-filled structures with acoustic shadowing. Failed intubation produce two filled structures referred to as double track sign, and the transcranial ultrasound is 92 to 100% sensitive and 100% specific in pediatric patients. Successful endotracheal intubation yields a single air-filled structure, and double track sign could be also used to confirm the presence of nasogastric tube. And this I can show you. This patient with failed intubation or esophageal intubation, we have here the tracheal ring and the hypochoric line, and the tube in esophagus, because the esophagus is collapsed structure. So when you put a tube and you put air through this tube, you're producing also air intermuscular interface. So you have double track sign. Here, the esophagus is collapsed. You have the successful intubation. You have single air track sign. So this is very most sensitive and specific intubation. Also, this can be, if you would like to use it, when you put the nasogastric tube and you would like to confirm an esophagus, after confirmation that you have successful intubation, you can find double track sign, but this is be useful also for confirmation of the site or of the nasogastric tube. It is in the esophagus. So it can be bad in the failed intubation and can be very good used for the patient with the nasogastric placement. The POC, the point of care ultrasound, can also be used to access depths of endotracheal tube to avoid endobrachial intubation by visualize the AT cuff balloon above the level of sternal notch in the long X view. Also, the point of care ultrasound can be used to confirm bilateral ventilation, both lungs, by the presence of the bilateral sliding of visceral pleura against the parietal pleura during ventilation using either B mode or M mode. And we are going to find that more to explain it when we're talking about the pneumothorax. How about the prediction of the appropriate diameter of endobrachial tube? The point of care ultrasound, the POCUS, is our BOC, POCUS, is very helpful for measuring diameter of subglottic upper airway at the lower border of cricoid cartilage in transverse view. They found also this is correlate well with MRI scan. The left main bronchus, the proper size of the left-sided double lumen tube can be estimated with the point of care. And this is very important in children or teens, females and males, to find what is the proper side of the left side or the double lumen tube. So the outer diameter of trachea, we found it measured at the level of the sternoclavicular joint in the transverse view. And we found that the ratio between the left main stem bronchus and outer diameter is 6.8. And this is the ratio. So if you got the outer diameter of the bronchus, of the trachea, 6.8 of that, you're going to the left main bronchus. And has this been confirmed in MRI and the CT scan measurement? Here, the transverse view beneath the cricoid cartilage to measure the diameter of endotracheal tube. And this is very helpful if you are in doubt in females, for example, or in a small patients, in pediatric patient, to identify what is the proper size of the tube, because you can measure the internal diameter of endotracheal tube. The other important, how you can predict the development of a stridor after extubation. Prediction of the post-extubation stridor and upper airway edema. You know that to develop a stridor, you have either the vocal cords are become edematous, or subvocal cords or upper airway edema, or the subvocal cords edematous. So the airflow during inspiration and expiration, or the mobility of the vocal cords, are being limited. And this can lead to the stridor, and it can produce the high-pitch wheezing and high-pitch stridor or after extubation. The first group talking about that were Ding group, and this is in 2006. And they did the very interesting. They measured the difference in airway column at the level of the local cords in the transverse view of the thyroid cartilage before and after endotracheal tube cup deflation to use. So before extubation, the patient, they measure the airway column before deflation and after deflation of the airway of the endotracheal balloon or cuff. You have to understand that when you have the cuff inflated, the airway column, and which appears as hyperechoic or whitish in the ultrasound, and you can remember that when you're doing, for example, the regional blocks or something like that, and would like to be, and you're putting the catheters, and you would like to identify the catheters, you're injecting 1 to 2 cc's of air, and you're going to find the tip of the catheters be identified as whitish or hyperechoic, because the air is hyperechoic. So, because the presence of inflated cuff can decrease the airway column. So if I decree of deflated and I measure the airway column, is going to be larger in deflation rather than the larger than inflated. So they found that the air column width difference less than 1.6 millimeter had a sensitivity. So if you have the airway column during deflation is less than 1.6 millimeter, less than the airway column of the during inflation, that's can prediction of the development of the post-stridor extubation. So they found that 70% with high negative predictive value and also positive predictive value. Another group, the Al-Marosi did that or confirmed that result, because Deng et al. Did that in 2006 in adults in ICU, and Al-Marosi did that in children, found that in 400 children, 44 developed post-extubation stridor, and they confirmed that test sensitivity of 93 and specificity 83 and accuracy of 91%. So that is also with confirmation when you're doing the Miller test for extubation, when you are measuring the airflow during when you're measuring the difference in airflow for the air leak test, when you have the airflow more than 100, that's an indication that the patient has no upper airway edema. However, less than 100 usually can prediction of the airway edema. And this is, can you see that the airway column here, as it is, as you see, it is hyperechoic, and the airway column, it is hyperechoic. And in A, you have a transverse view just below the cricoid cartilage with endotracheal and the cuff inflated, and the bullet-shaped air column, no change in width of air column here. You have seen here the airway column with the cuff inflated. However, here the airway column with the cuff deflated. If the difference between the deflation and inflated less than 1.6 millimeter, that can be indication of the development of the upper airway edema or vocal cord edema. Another group of India make a different test. They're using the same technique, but with different tests. The different test that they found that they put it also in the transverse view here between the thyroid and the cricoid to see the cricothyroid membrane. And they measure that ratio between, before the extubation, when the cuff is inflated, when you intubated the patient and they deflated the cuff and you measure the airway column, and after and before extubation and the cuff deflated, and you see the difference here, 0.75 centimeter, the distance of airway column, and this is immediately after intubation with the cuff deflated. And here, before extubation with the cuff deflated, and you found that the difference is the distance is 0.42 centimeter. And they found that if the ratio between the airway column after intubation and the cuff deflated, and the ratio between that and the airway column with the cuff deflated before extubation is less than 0.8, this means significant for prediction of the post-extubation stridor. And this is very intuitive. If immediately after cuff intubation and you measure the airway column with cuff deflated, it is higher than that before extubation with the cuff deflated. For example, this means that the upper airway edema can be developed. So they found that the difference in airway column ratio, width ratio, 0.8, that is prediction. Is less than 0.8, this means the prediction of the stridor. And this is quite intuitive, of course. So also we can diagnose the obstructive sleep apnea. Width of the tongue has been measured in the transverse view by the point of care ultrasound, correlates with the severity of related breathing disorder, including patient sensations of the nocturnal choking. So also the most important localization of the CTM to perform for the performance of the cricothyroidotomy and the transcranial injection, transtracheal injection. Cricothyroidotomy is one of the core skills for upper airway management. Success rate for correctly identifying the CTM by landmark technique varies from 32 to 39 compared with accuracy of ultrasound. CTM usually dimension 8 millimeter by 11 millimeter, and the cricothyroidotomy can perform in using a real-time ultrasound. How we can do that? Very simple. Use the high-frequency transducer, placed in the transverse short X view in the patient's neck, just above the suprasternal notch to visualize trachea, which is seen as the inverted hypoechoic structure with hyperechoic, the air interface, reverberations. And the transducer then rotated 90 degrees to visualize the tracheal rings as a string of pearls or a string of the bead of strings. Tracheal rings will appear as hypoechoic strings anteriorly to hyperechoic AM and interface line. Transducer should be moved kefalad in the long axis to view in the midline until the cricoid cartilage cuboid in shape is visualized. Transducer is then further moved kefala to identify thyroid cartilage. The echogenic CTM will be visualized between the cricoid and the thyroid. Needle should be inserted using real-time ultrasound. Cricothyroidotomy should be performed after that in the traditional way. Also, I can use it for the transcranial injection of the local anesthetic for blocking the recurrent laryngeal nerve during awake fiber optic intubation. And here we go. You have here the tracheal ring, pair of strings, and you have here the cuboid shape cricoid, the CTM, cricothyroid, and the thyroid cartilage. And here the cricothyroid membrane, you can use, just move it just laterally from the midline, the transducer, in order to use the out-of-plane technique of the needle, and to have the real-time ultrasound for insertion of the needle. Also, we can use that for vocal cord assessment. Translaryngeal assessment of the real-time vocal cords movement is useful and reliable method after thyroid and the parathyroid surgeries. Linear transducer is placed in the transverse view anterior to the midpoint of the thyroid cartilage. Vocal cords are hypoechoic, but may be distinguished by the fine hyperechoic, which called the vocal ligaments at the medial edge. Vocal cords movement and arytenoids, false vocal cords and arytenoid are hyperechoic, and we can ask the patient to phonate, and we can see the adduction and abduction can be seen with ultrasound. Here, the ultrasound in the open glottis, and here in the closed glottis. Can ask the patient to phonate or saying ah, and we can see the movement of the vocal cords. They found that the success rate of the true vocal cord visualization reduced with calcification of thyroid cartilage, as we mentioned. A prospective study of 529 patients scheduled for thyroid or parathyroid surgeries. Preoperative ultrasound was successful as a screening tool to evaluate the vocal cord movement in 84% of the patients, allowing visualization of the vocal cord abnormalities for invasive flexible bronchoscopy. And even after surgery, you can apply that for the patients before you apply the bronchoscopy to ensure that the intact vocal cords after thyroid or parathyroid surgeries. Here, also a very important application, diagnosis of the pneumothorax. Ultrasound is an effective and a chest radiography and finding or excluding pneumothorax. Ultrasound is even more sensitive than chest X-ray. It can establish pneumothorax. It is invisible in chest X-ray, but diagnosed by CT scan. Pneumothorax can be diagnosed by loss of lung sliding and dynamic interaction of parietal and visceral pleura and B mode. M mode is usually to confirm by adding the loss of a sliding sign. The B mode used to confirm, this is wrong for me, sorry. In the presence of the lung sliding, the pattern of M mode is known as the seashore sign. In pneumothorax, the M mode is not register any movement of the pleural line, as extrapulmonary soft tissues remain as a still linear image. Pattern is called statosphere or paracode sign. Absence of sliding sign can be used to confirm also the single lung ventilation in thoracic surgery. And this is very important. Here, the patient, you have the ribs, you have the pleura, and absence of sliding. Here, pleura is moving, and this is no pneumothorax. Here, pneumothorax. Here, you have the seashore. We have here core, the patient with M mode. You have here the paracode sign, and here it is like the seashore. You can use that for pneumothorax and also for when you use it for double lung intubation, single lung intubation, when you are clamping the right or the left, and you can put the ultrasound, you can see that there is movement or not. And this is a confirmation, and we use that very nicely during our single one lung ventilation. We use ultrasound for confirmation after we use the bronchoscopy for proper positioning. And especially during surgery, you can put the ultrasound to confirm that you still have one lung ventilation. Also, you can use it for the internal branch of the superior laryngeal nerve block for either upper airway block or the awake, especially the awake fiber optic. The internal branch of the superior laryngeal nerve passes inferior to the greater horn of the hyoid bone and pierces the thyrohyoid membrane. It provides sensory and innervation to the mucous membranes of the larynx above the vocal cords, as well as the base of the tongue and epiglottis. External branch, it is motor to the cricothyroid muscle, and this is affecting the pitch. And high frequency usually is placed over the midline to visualize the thyroid cartilage and the hyoid bone, and then moved laterally to visualize the greater horn of the hyoid bone and the thyroid membrane. Thyroid membrane as can be, it is hypoechoic, but once you see the hyperechoic of the air muscular interface, that is can give you an idea where is the thyrohyoid membrane. Once you see that, 22 gauge needle can be inserted in the either in plane or out of plane technique. 1.5 ml of lidocaine, 2% can be injected in each side, and it is quite sufficient to do that. And this is what you see here: hyoid bone, thyrohyoid membrane, hypoechoic, but beneath it, the hyperechoic AM interface. Once you see that, you can pierce the needle and injecting the local anesthetic here, and you have the very successful block for the internal branch of the superior laryngeal nerve. It is very helpful for awake fiber optic intubation. Lastly, I'm going to speak about diagnosis of epiglottitis. Acute epiglottitis is life-threatening disease. Ultrasound has overall sensitivity of radiography in detecting epiglottitis is 89.4%. Linear transducer is placed in the transverse short axis view in between the hyoid and the thyroid cartilage, hyoid bone and thyroid cartilage, or above the thyroid cartilage if you would like the easier way. In this view, epiglottis will have as a face appearance as we mentioned before. And we have the two hypoechoic eyes are the sternohyoid and omohyoid muscles, and the mouth is the cross-section of the epiglottis. And epiglottis appears as hypoechoic structure, as we mentioned, and behind this, the hyperechoic AM interface. Thickness of epiglottis is usually measured at the middle of the hypoechoic structure. Normal mean epiglottic thickness is 0.239 centimeter. With greater thickness in male than in females, increase of the thickness twice the normal should raise the suspicion of acute epiglottitis. Here, as you see, transverse view, linear between the hyoid bone and the thyroid cartilage and the upper limit of the upper border of thyroid cartilage. You have here the epiglottis. Deeper to it, it is the hyperechoic. This distance is usually 0.2 centimeter, and if double the normal usually raise the suspicion of epiglottitis. Another image here, the patient with epiglottitis, as you see, and here the thickness is the width of the epiglottis is double the normal. Here, after treatment with antibiotic, becomes back to normal. And lastly, I'm going to end with ultrasound has many advantages for imaging the airway. It is safe, quick, repeatable, gives a real-time dynamic images relevant to the several aspects of airway management. Thank you very much. Thank you very much for wonderful listening.
Yeah. Thank you very much, Dr. Ehab, for these interesting lectures. We have two questions from Dr. Abdul Salam. First, he asking about the nerve block. And I think you already mentioned it in the superior-laryngeal nerve block. And he's asking regarding we can do nerve block for tracheostomy using the ultrasound. Can we do that?
If you are going to use that's very simple, because you are going to use it for the recurrent laryngeal nerve. So and the recurrent laryngeal nerve supplying the nerve supply below the vocal cords. So if you are numbing or doing the transtracheal injection of the recurrent laryngeal nerve, that can provide the blocking of the tracheal rings as well.
All right, yeah. And he's asking also about the leak test. Can we do it in the patient with tracheostomy as well?
I think yes, because you can, as we are measuring the airway column with inflation and deflation, we can apply that also with the tracheostomy. But I don't know about the measurement, because all the measurement did in the patient with endotracheal tube correlation with the leak test. They found that the patient with leak test above in the 190 millimeter difference of the leak, that can completely no stridor. And they found that the patient developed stridor about 112. So I'm not sure you can apply it or not, but I don't know about the measurement, because all the measurement done in the endotracheal tube. But you can try.
For myself, I have some question or comment. You present a case who developed stridor 3 hours at the end of surgery because the increase of air column. It is increased 0.1 centimeter only. Is it significant to cause stridor in adult patient?
To be honest with you, I don't know. I don't know. It might or might not, but I don't know. I have to admit.
Actually, if in pediatric, I can understand, but 0.1 centimeter in adult, he is intubated 7.5 or 8 tube, developed stridor. Anyway,
I cannot answer that question. I don't have a definitive answer. It is, I already took what they written about it. I know what you're talking about, but might be prolonged, because you have the patient with prolonged intubation and developed some sort of edema, and this might be
maybe. Comment from Dr. Moder Shaker. He is asking, can we have a protocol step by step for the assessment of the airway? You mentioned a lot of idea, but can we start from 1, 2, 3, 4? Can you?
Yeah, because when you look at my presentation, I started from A to Z. You started from the floor of the mouth, and then you can go to the hyoid bone and the thyroid cartilage to see the thyrohyoid membrane, and then you can go down to see that the thyroid cartilage and to see the larynx. So from the A, B, C, you can do that. That is that's a systematic approach. Like when you intubate from the mouth and then down to larynx and then down the trachea. You go from up to down.
All right, yeah. Another comment from Dr. Ahmed. He is talking about the ultrasound in difficult airway. There is no textbook mentions that, and I think I remember you mentioned some reference in 2022. A prediction of ultrasound in difficult airway is not established yet. So what is your comment?
I mentioned that it is not established, but ultrasound can give you an idea. It is difficult intubation versus simple intubation. Use the ultrasound, use it as routine. Can give you an idea if this patient is difficult. If it's not difficult, that's fine. But if it is difficult, or if you are assuming it's difficult, have the other tools, and people will be prepared. If it gets easy, fine. If not, you are already prepared. So why not?
Yeah, okay. Another question from Dr. Raka from Argentina. Actually, he's usually with us in Abu Dhabi Anesthesia Club, and he's asking about the evaluation of the diaphragmatic functions by ultrasound.
If he would like to know about, of course, I didn't have enough time to put all of that, but ultrasound evaluation of the diaphragm, I can reference him to go to my paper I published in 2020 about using the Zogamadex in the published in Anesthesia and Analgesia, Zogamadex in the neurointervention suite, and we use the ultrasound for the diaphragmatic evaluation. And simply like that, you use a curved probe, and in the right side in the mid-clavicular line, you are going to find the lever and you're going to find the diaphragm. And then shift to the M mode, and you're going to go to the diaphragmatic movement by the M mode. And then you go to the left side and then keep moving lateral until to find the spleen and the diaphragm. And then you can visualize the diaphragm and also shift it to the M mode, and you are going to find the movement, and you can ask the patient to breathe deeply and normally, and you can also measure the speed of contractility of diaphragm. I explained that very well in my paper.
All right. Maybe because of the time, I have just 2 questions for you. First question, when we should do the ultrasound assessment for the airway for the patient? It should be in all patients. And if we are going to do it, it is better to do it in the pre-anesthesia clinic or just pre-induction?
It depends upon your time, to be honest with you. If you have time pre-induction and you have time to see the patient, especially if they're expecting difficult airway, especially if you are planning to do awake fiber optic, so this is a pre-induction. If you have time in the pre-anesthesia clinic and you're expecting difficult patient or expecting upper airway, that you are a difficult airway and you need to do awake fiber optic, the ultrasound assessment is very good. Especially you have to get, it is not an easy, you have to get what we say familiar with the technique and handy with the technique several times. It took from me a couple of times in order to get used to it in the upper airway. It is not an easy as in this is in a very steady, very nice patients, not our patients with sick neck, and you have to be familiar with that. But this is a very good, important tool.
All right. Thank you very much, Professor Ehab. We enjoyed a lot your lectures.